So we heard from Jenny a real sort of clarion call, a real challenge to all of us today in terms of how we manage that shift from treatment to prevention, but also how we approach that with creativity, as Jenny was saying. I think that's a really important aspect here. And I know all of you are involved in this shift and are the people helping to lead it in a lot of ways. And audience as well, just to prime you, I'm going to ask a few questions of our panel and then I'm going to open it up to the floor, because actually we've got a lot of great people in the room and I want to hear what you have to say and what you would like to hear from our panel as well. So firstly, I want to talk about prevention. So a key element of prevention is moving outside of some of our traditional care settings. So not always having that the person comes to the healthcare. So when we're thinking about that, community settings, co-creation, and actually something Jenny was saying about listening to our communities, how do we achieve this? So I wanted to come to you first, Janet, to talk about the ways in which you've been embedding services into communities, but also how you've been involving communities in the creation of those services.
As part of my work as head of sustainability, the main overarching part of that is actually ensuring that the benefits that our services delivers to our patients or community is actually sustained, and that's the bottom line. And also to ensure that what we do is financially sustainable so that we can continue providing the service. And at the same time, the excellence of care and the patient experience is sacrosanct. And I just wanted to put it across. And also that it has to be good for the environment, because that's part of our duty. So what we have been doing is actually what I call, we involve our different departments to look at what their care pathway and how we can actually be best implemented, and seeing that, as we know, everyone I think knows that in the NHS and even other health service, demand always outstrips the provision. So we've been trying to manage that demand, and in fact, a lot of the initiative that we're doing actually is to prevent that demand, to actually take that demand out from the acute setting and deliver it in the community. But still, that's still more of an intervention when they're already sick. So it's not actually prevention. So what we're doing, let's say, for example, with Walsall Together, that's one of the initiative that one of my trust, Walsall Healthcare, actually is involved, is looking at what is the cause actually. So if this is a patient and presenting anxiety, so is that actually the issue? We tend to treat the anxiety rather than the root cause actually what is causing the anxiety. So connecting with other services, then we can actually say that actually the person has problems with housing. So they're about to be homeless. So which means then that by treating the issue of homelessness might elevate actually that issue of anxiety. So you're preventing the person from going into the road of the mental health system. So that's what we're doing. We're trying to look at how we actually prevent from people from entering the system. But at the same time, as we know, we need to manage our demand, our capacity, etc. We're also doing that. But for me, what I'm going to say is that it is important when we're talking about prevention, actually it's important to look at each of the individual and actually making them responsible for their own health, but then also providing them that capability to do that, to make that informed decision so that they don't actually need to go into, they know how to seek the proper interventions first or help first before actually addressing that resultant issue because of the other. And that's what we call about social determinants of health. We need to address that first and see what's causing it. So, and that's the train that we are doing. It's difficult, very difficult, because for the last so many years, 70 years now, the NHS has been quite focused on the acute side of things. So when you get sick, you get this intervention. But the capability building, keeping people realize that actually if you engage in what I call risk behaviors that actually put your health at risk, then that becomes then an issue. You get entered, but we haven't addressed that so far. The things that we are doing, we're co-creating, which is a really good start, but we haven't really addressed about that individual capability to make the right decision, informed decision on how they maintain their health.
And I think what you're laying out there is truly person-centered care and attitudes, because exactly as you're saying, it's not just about multi-sectoral collaboration as a nice to have and as a sort of a catchphrase, but actually that's the root cause of that person's anxiety, is the fact that they're in unstable housing and things like that. I think that's a great point. And also your reflection in terms of the way that the system is set up in terms of being sort of reactive and mainly around acute services. And Marius, I wanted to bring you in here in terms of what you've been doing in Romania and how have you been sort of addressing some of the similar challenges in terms of moving towards prevention and promoting health rather than just reacting to ill health.
Yes, thank you. And thank you for having me. I'm very happy to share insights from the EU-funded projects that Inomed, my organization, is implementing currently in Romania, both on cancer primary prevention and cardiovascular health. So are actually separate projects, and nobody from the European Commission or HADEA asked us to, build synergies between cancer prevention and cardiovascular health, but people in the communities share with us their needs, who are actually combining risk factors, diseases, and so on. So what we actually are doing now, we are implementing in rural Romania, in a village, a living lab. So the living lab, it's a method who allow us to start by identifying the stakeholders and the needs, then to generate an idea, to build a prototype, and to implement. And this living lab, we decided to go to rural Romania, knowing that 50% of the population, not only in Romania, but in the EU, are living in rural settings, and 60-70% of the territory in the EU can be considered a rural area. So if we'll be successful, and I'm sure that we'll be successful, in building a model on how to deal with primary prevention in rural settings, this will be highly informative, not only for Romania, but for rural settings across the EU. The idea at the beginning was, we all know the risk factors for cancer, and the European Code Against Cancer was launched 40 years ago, and in 3 weeks we'll have the 5th edition of the European Code Against Cancer to be launched at ESMO Congress. It's the same for cardiovascular risk factors. We all know the risk factors. We don't need, let's say, scientific evidence to prove that, I don't know, smoking is bad or alcohol consumption and so on. What is missing is actually the real implementation, and to understand from implementation what is good and what is bad. And this is happening because, to your point, we are not usually looking to the social determinants of health and to individual behavior. And this consists about 60-65% of the health determinants. And what we did was actually to look to the primary prevention through the lenses of individual behavior and social sciences in this community and in this rural setting. And what we did was to simply went to the community, but not alone, with a multidisciplinary team, with social scientists. And what we did was to use advanced social sciences methods and tools, network science, personal and social network analysis, to understand on one side what are the relevant stakeholders, and on the other side how actually different behaviors, risk behaviors are spread. And I will start with the second part, very interesting. The biggest predictor for me to become a person with obesity, the biggest predictor is the number of people with obesity in my personal network. And is the same for smoking, and is the same for alcohol, for poor nutrition, and so on. What I'm trying to say, the prevention is not only an individual choice, but is so much linked to our immediate environment, without the social tissue around us. And this is very informative, because now we're looking to move from one size fits all type of doing prevention campaigns in the community to network intervention. In other words, we identify some nodes, very influential people in the community, and they are now ambassadors in our projects, and we are working very closely with them, and we'll try to use them actually to spread and to try to see if the good behavior spread to their networks, and if they can influence the other people. And on the stakeholder side, this was really, really interesting, because if you look to how actually the primary prevention campaigns are implemented, you can see from global to very local level, maximum 10 stakeholders involved, from WHO to family doctors in a community. But our analysis shows that are 128 stakeholders involved at European, national, regional, and local level, a big number, but as well using a methodology called NetMap, we identify the relevance of the stakeholders. And at the local level, where the local authorities and especially the mayors, as the most influential at the local level when it comes to the prevention. But usually the mayors and the local authorities, they don't have a proper role when it comes to prevention. And we try actually to start working with them and to build a model, and somehow to link them with the health system, with the family doctors, and let's say the traditional way of dealing with prevention at the community level.
So you almost have to, create them a role and then let them know what their role would be. Yeah. And Marius has already talked about cancer and also cardiovascular prevention. And obviously, Thomas, it's an area that's so ripe for prevention, isn't it? Cardiovascular care. So what have you seen that's already working in terms of sort of trying to move towards a more prevention-focused model, and where have you seen technology really helping to enable that?
Yes, I think in cardiovascular, to prevent heart attacks and premature cardiovascular death, we know what to do, but and we also tell patients what to do, but we're unable to implement it, and I have been in this business for a couple of years, and it hasn't changed. People know about blood pressure. By now, they even know their blood pressure. Often it's not well controlled. The perception of a optimal blood pressure, also among GPs, is still old-fashioned. And many people don't know their cholesterol and whether they have, diabetes or pre-diabetes and so forth. So I think the most important thing is know your numbers, and that surveys show that many people know the blood pressure, they don't know the other risk factors. Mm-hmm. We did actually several meetings, cardiovascular roundtable with the European Society of Cardiology, to see what works. And education alone clearly doesn't work. SMSs, a little bit. I think the artificial intelligence will be the future in my mind. And the situation, of course, is as bad in primary prevention as in secondary prevention. We did a large study which just submitted to the Lancet this week, where we looked at 80,000 patients undergoing stenting, a percutaneous coronary intervention for an infarction. and their lipid control is very bad. In fact, those who don't measure their lipids after an intervention, they have an increased mortalities. The ones that reduce their drugs because they feel they take too much drugs, they have an increased mortality. In England, we can really look at this precisely thanks to the registries we have. So the situation is really very bad, and what can we do about it? There's a big European grant where we are also involved, where it's called Cities at Heart, where in cities the intention is to do checks, health checks for people, so they know their numbers. Because if you don't know their numbers and what it means for you, you will not do anything. And this is also a big program at the European level. I have contact with the commissioners of health, and now yesterday I was in Brussels with the commissioner of climate, also for nicotine, how to curb smoking. They are very much into that. There is in discussion now a cardiovascular health plan that focuses on prevention at the European level. Of course, we're not in the European Union. I tried to be there when I came from Switzerland to England, but I'm out again. So, but anyway, I'll try to keep the contact with the European Union as the president of the European Society of Cardiology. And of course, for Horizon, which is a big research network, we are able to be part of thanks to Theresa May, who signed this contract. And so this Cities at Heart research is one example. I do believe that just talking to patients alone, it doesn't work. We're currently developing an app, an artificial intelligent and enhanced app. Everybody has an iPhone. Now, it has to work for the grandmother as well. So you must be able to talk to it. And the first thing is when you leave the GP, 60% of the people forgotten what they were told. Mm-hmm. So we need to tell them what they have and what it means repeatedly. Then also know your number. Did you ask your GP what your LDL is, what your blood pressure is? We would suggest it should be this and this and that. And you can, with AI, you can do it in several languages. So if people are not very, fluent in English, you can do it in their native language. You can also adjust the level of language that to make it more pedestrian or more sophisticated for intellectuals. So that's what we're working on, and of course, we saw also that the GPs have to be instructed to actually work on it. So this is an attempt that we do for primarily in secondary prevention because that's easier. People had an event and they are a bit shocked from it, and the motivation may be better. In primary prevention is more difficult. And so one thing that I think would work very well that my good friend John Deanfield implemented is the heart age. So you do a check and they tell you do this with 52 because you thought now it's about time to do it. And you go to your GP and you get all these things measured, and then they tell you your heart age. And if your heart age is 45, you're happy and you go home in good mood.
Depends what your actual age is, though.
Well, 52, I said. So if it's 45, you're happy. But if it is, let's say, 55 or 60, which can be truly the case, then you wake up. And I think to adjust your age to your calendral age is one thing, or ideally be actually younger than that. That probably would be the ambition. So we need intuitive things like this. Also a thermometer, where you have amber, yellow, amber and green and red. And then you start in red and then you can see how you improve. These are intuitive things that work for the midbrain. So it is a challenge to implement what we have. That's really the implementation. Science should be fostered by grants because any means of motivating people and sustain it. I mean, you can be successful like for weight loss programs for 6 months, but that doesn't change the situation. It has to work for years. Otherwise, there's no impact.
Absolutely. And I think there's two particularly interesting things that you'd mentioned there. One is around the registry data that you were using, and that's something that I heard a lot yesterday was actually we don't need more data. Quantity is not the problem, quality is sometimes the problem, but it's also about transforming that data into something that we can actually use. And I'm giving you your next warning that I'm going to be coming to you for questions soon. But Katie, I wanted to come to you next because as Thomas was saying, we know what works. Many of us as individuals, as well as, people working in health, know what we should all be doing. So how are you at Vitality sort of trying to help people to make sense of those numbers and turn those numbers into action and change?
Thank you for bringing me in. I mean, fascinating stuff and so many bits I'm going to pick up on what other people have said. So Vitality, I mean, everyone here probably knows Vitality's health insurer in the UK, but we've actually been doing this internationally since the early 90s. So we operate under the basis of what we call the shared value model, because actually we are the one place in healthcare, even as a private company, where what is good for us is good for our members and is good for society. So if we can get people healthier, this is actually only going to benefit everybody. So we've been doing this for a long time. We've got the Vitality program. This is now across the world, as well as in the UK. I think we are the largest wellness program in the world now. And it is very much about that. How can we essentially reinvest what we would call the actuarial surplus that comes out as an insurance company back into helping people to get healthier for all of those benefits that I said? But I think the key thing for us, so we've operated since the 90s under a very simple 3-step model. One is help people to understand their health. We've got something called the Vitality Age, which is very similar to the Heart Age, which is works under exactly the same principles. So we have a kind of global number for helping you understand your health. We also have red, amber, green dials for individual metrics. So we're picking up on all of that, but really helping people to understand their health, both from a paper perspective, as well as get all of those various different screens in place that you need to do. Number 2 is help people to get healthier. So make it easier for them to get healthier. So make it more accessible, whether it's healthy food, whether it's doing physical activity, whether it's helping improve their mental well-being, whatever that might be, making it both physically and financially easier for people to get healthy. And then the third point, which I think is the unusual point, which is what most people know us for, is and incentivize them for doing that, right? We all know about all of the kind of health economics principles, behavioral economics principles that sit behind the fact that actually it's really hard to do something today for all of those benefits down the line that you're going to see. And so we try and bring that closer. So we have a series of rewards that come in daily, weekly, monthly, annually to say, we'll bring that reward if you do that because of exactly what I was saying, which is the actuarial surplus that we get if you get healthier. So we've put all of that into place. I think the interesting thing, particularly on data, is to some extent, we then have this huge benefit of actually being able to see the end-to-end data. And I do think there is a challenge. Whilst I think kind of globally we've got a lot of data, I think often connecting those data systems can be really, really challenging. So we can look at how people behave and then what that means from their health claims perspective, as well as their life claims perspective. And we've got really good evidence to say that, people who engage in the Vitality program are over 20%, have over 20% lower claims cost on a health insurance policy. On a life insurance policy, they live 5 years longer. So, we've got some really good data points to say, and this is effective. But I'm going to come back to one of my real bugbears that I was boring you with earlier, Elly, which is, we really invest in that research to say, if we come in at this point, what is that impact going to be down the line? And I think that's one of the biggest challenges that we have in health improvement and prevention, right? We've got a plethora of things now out in the market to help people to get healthier, whether it's screening, whether it's physical activity, whether it's a new app, whether it's a new nutrition advisory, whatever that might be. But where we really, really are lacking is on the research basis. And the challenge you have as a commissioner of services, and in many cases, I'm a commissioner of services. So I commission weight loss services for my members. I commission smoking cessation services for my members. But what you find is because of the limited investment in the research upfront, so unlike pharmaceuticals and many of the medical devices, you have limited investment upfront, right? These are usually smaller companies. They're often private equity backed. They have a very different funding structure. They come to us as commissioners to say, please fund it. But then you have this responsibility for funding and then researching kind of through the process. And I think it's a real challenge both in the public sector and the private sector for this commissioning gap that we have for real world-class commissioning of these services. And one final point I will make is around the kind of post-market surveillance of a lot of these services, because we really, really intensively then kind of look at what the impact is down the line. But actually what you see, particularly, and it's very relevant for AI and what's coming in now with AI, is when you look at some of the things around regulation on post-market surveillance, because of its origins in medical devices and pharmaceuticals, it's very focused on incidence as opposed to efficacy. Right? Because in principle, for pharmaceuticals and medical devices, efficacy has been done already, right? It's gone through phase 3. We've done all of that. So now it's about incidence in post-market surveillance. But if you look at AI, digital tools, health improvement and prevention, you haven't done that initial piece yet. So actually, you need efficacy analysis within post-market surveillance, and we just don't have that in place. So that's why we hugely invest in that. And as I say, afterwards or in the break, I can share any of the data with people around both at an individual programmatic level as well as at a kind of more global program, what the impact is of the various different things that we do. But I think generally this is going to be one of the biggest challenges in health improvement prevention, and particularly where it links to AI tools.
Yeah, exactly. You need to have that evidence of effectiveness and also the sort of return on investment as well, which obviously in prevention can be harder because you're talking about averted outcomes and sometimes and it's a lot more challenging, isn't it? And I wondered whether maybe Janet, you wanted to come in on this in terms of the work that you've done. You know, how do you measure the impact? How do you demonstrate return on investment for services?
Yeah, for example, we've got a service that's actually started a program with our children in special needs. So orthoptic services is doing that. And the first thing that they did was actually do a focus group discussion with the parents, existing patients, and ask them exactly what is it that we could do to improve. And one of the things that they've said is actually when they come into hospital, because one of the things they realize that why are we only seeing 4 patients per session instead of maybe more? And when the parents were asked, it's about then they don't know really, they don't have the information when they are called for the specific clinic. When they're called, they don't have all the information on what happens, where do we, even to the point of where to park, where to find the department, and what to expect during the session itself. So, and they wanted to know as well, you know, what the condition is, what, you know, why they need to be seen by the doctor and all. So what the team then had done is that, and that's part of greening their care pathway, is that what they've done, they've decided to do what we call a virtual clinic, where they actually, that virtual clinic is a preparatory session before the face-to-face session. And what happened then is that they've actually, in terms of the productivity, they're able to see 8 patients now instead of the 4, just because the parents and the kid is now coming in with all the information that they need, and they're more the kids are less anxious, so they're more cooperative on the things that's done. And we also did a post session. So after the session, there's a follow-up. During the follow-up, they're asked their experience, and then the team is building on that then, and actually doing it for the others, and because it also cut their waiting times. So it's good for the patient. They know then what, and even the patient know that the prism needs to stay there, instead of them like trying to, because it's a bit funny the first time they put it on. So there is the individual capacity building, which actually then makes the service more interactive and more co-created, and the patient experience and the result, the care result, is better. So it's sometimes it's we need to actually speak to our patient rather than the service being given or provided, but actually, let's be there. And it takes resources. It would take time, but we need to start. And that's one of the things that we're doing. We call it greening services club, but actually they look at care pathways for the cohort of patients and say how we can actually make it better. How we can make it better and make it more sustainable, and making sure that we're targeting, because anything that we do, we actually make sure that the care, the excellent care is there, the excellent result is there. The same way that one of the things that we've done in RWT is we stop group and save for prostatectomy, robotic prostatectomy procedure. The reason for it is that when we look back at data, actually, there has never been an issue with bleeding. 170 mils is the most. So we said, why are we bringing patient to the trust, getting their blood, taken, group, and then save them just in case? And you have to bring them, you have to, with me, you need to find it. And I always end up black and blue. So and also, trying to find parking and paying for parking in hospital is issue. So what we've done, we said, well, actually, with the clinicians, say that actually there's no need for that. So it's been stopped now for the last 2 years, and we've never had any issues with it. So it's about then looking at, cutting things that are actually unnecessary and making sure that, and when we ask the patient, is it, what did it happen that you don't need, that's such a relief because you know how it is. I live like about 20 miles from here and coming in and finding, and the anxiety of trying to get into the clinic as well. So all of that can be done. And they know then that was the reason why they didn't have to come.
And that's a great example of combining something that is an unnecessary intervention potentially. It's also saving money for the trust, but it's also thinking about the patient and what is important to them. And I do want to open up to questions.
Just if I may comment on this, basically we've discussed in 30 years about measures to improve prevention, and most of it doesn't work. We need, as has been said earlier, we need randomized controlled trials to determine whether this is worth the effort and the investment or not. And there has been a few, and most things don't work. And we have to really find new ways, and that's why I think in the age of digital cardiology, we have to test now these measures. And just, many things that intuitively work, like talking to the patient. The data show that the patients forget it. They may do it for a while, but there's no sustainability. So we really need to test things. Evidence is required. Otherwise, we invest a lot of work and money into things that intuitively look good, but don't work.
Yeah.
Just to briefly add, I absolutely agree. And based on our experience, at least for primary prevention, what is, I think, really important is to consider cultural factors. We are actually doing ethnographic studies to understand, because the risk factors and behaviors are so much embedded in local culture in different ethnographic aspects and so on. And that's why, and I think you, Professor, you mentioned the need to invest in implementation science. I think this is crucial, and action research. In other words, to go in a region, in a setting, doing implementation, but always from the beginning applying the methods and the tools that allows you to understand what is going on there, and then to generate the ideas for research, and then to implement, and so on and so forth. I think, at least for primary prevention, I think this would be a nice way actually to move forward, and to somehow to move from what has been done in the last 30, 40 years to something more dynamic. And I think from this perspective, the AI and especially generative AI could help us a lot.
We need a digital twin of
Yeah.
the patient with all aspects of his
Exactly.
environment, of his culture, and his
Exactly, digital twin of a person, digital twin of the network of a person, and digital twin of the community where a person is living in. And this is what we're trying now to build based on this data.
Very good.
Fantastic, thank you. And I'll open up now. So we've got a question in the middle here, please. The most challenging spot to get a microphone to. If we can keep your question brief so that we can get to another person afterwards, please.
Hello.
You
Just shout.
project, yes.
Yeah.
Thank you very much. There was some golden thread running through around some behavioral psychology, behavioral economics, incentivization, gamification. I'm just really interested in how you feel that can apply to the public sector perspective, where we don't own all the data within one institution. We maybe don't have the financial resources that Vitality have, or the financial incentives that Vitality have to do certain things. Are there specific interventions that you think could be applied into a public sector context?
It's a great question, and I spent a lot of time having exactly this discussion, which is how can we take the model that we've used and actually move that into a public sector context. And so I think in terms of, I think there are a few different components to that. I mean, one, you've mentioned data, and I think being able to follow end to end can be incredibly challenging depending on the data silos. I think two, the economics of it are incredibly challenging, right? The person who pays isn't necessarily the person who benefits. And there's a lot of how can we actually kind of equalize that so that the person who pays benefits. And I do think from a structure perspective, how can you benefit in the short term? Because this is also often tied into short-term cycles, whether it's an election cycle or other cycle. It's incredibly hard to see those benefits. And as I say, we've been kind of committed to it since the 90s, which is part of the benefit. So I think that's part of the challenge. But in terms of what works, I think, you know, there are a couple of really simple pieces, and my challenge, particularly in the public sector at the moment, is the philosophy of if we build it, they will come, right? So there have been some fantastic initiatives set up, you know, the health checks, an amazing initiative, various different pieces, but actually you can't stop at that point, right? Just by setting these programs up doesn't mean anyone is actually ever going to use them. And there are some increasing challenges when you think about, I was talking to someone recently about things like screening, right? The longer the gap, so a health check is every 5 years, right? That doesn't fit into anybody's regular health cycle. An annual something might be more of memory, but the principle of if we build it, they will come is where I think it breaks down. So I think there are some simple things that can be done within a public sector environment to actually invest in the communication, let alone the incentivization around some of those services. So I think that's one. I think two is focusing on the types of services, right? There are some areas where we heavily invest, whether that is, you know, around around nutrition, around mental well-being, etc. But there are some really simple areas, particularly around things like physical activity, that aren't necessarily costly for anybody to implement. And I think, again, structuring those in the 1, 2, 3 steps. So how can you make sure people understand the importance and the impact that it could have on their health? How do you make it more accessible and easy? And then how do you incentivize? And I'm not talking necessarily about the enormous incentives that we put in place on the Vitality side of things, but how can you think in a structured way around incentives, I think is really important. So I think there are many ways in which it's applicable to the public sector, but what I've seen so far is great initiatives popped in place and then a hope that people will use them, and that's never going to work.
We're going to need to wrap it up in 1 minute. No, that was great. And actually, you've reminded me that I need to reply to my GP for my checkup. So thank you. There's a public health intervention for you right now. There was someone up at the back who had a question. So we've got less than a minute left. So if you just want to make it more of a reflection for the rest of the day.
Yeah, sure. Steve Lowe, I'm over from New Zealand. Last year I was over here actually at the IHI conference, and a big carbon footprint, but there was a focus on Costa Rica and the Nuka health systems later in Alaska. And the thing that struck me about them was heavy investment into primary care, creating community hubs, but both featured the use of health navigators, so people that deliberately, and in Costa Rica, they go into the home either 1 to 3 times a year, depending on on the need that's identified. So I just wonder whether that kind of could be applicable. I know it's pretty hard to apply that to Europe, but if you identified certain people, whether that could be thought of as a way of trying to get through to people.
Thank you. That's a great closing thought, because actually I did hear patient navigators mentioned yesterday, and actually some of the conversation we were having earlier, Thomas, about sort of AI co-pilots and things like that, I think could be really applicable here. So thank you for that closing sort of thought for us. So thank you very much to my panel. That's been a great discussion, and look forward to speaking to you over the rest of the day. So Katie, Janet, Marius and Thomas, thank you so much. Thank you all.